It's always a difficult one, isn't it, when you're faced with presenting on a topic which is about implementing recommendations, and I make no secret of the fact that I'm going to bypass a lot of the great detail and just sort of pick out a few points of interest that I think will be of importance for all of us here today. But I think first of all we need to just reflect on this problem that we're all here to talk about. And prostate cancer is important for many, many reasons, and not least of which it is certainly the most common malignancy affecting New Zealand men apart from skin cancers, and in fact it accounts for nearly a third of all of our male annual cancer registration. So this is a common problem. And the other thing about prostate cancer is that it just doesn't exist, but it is also a major killer. And that 600 men every year, when you put it in context, is now greater than our annual road toll. So when you think about the importance of this condition and the sort of resources and amount of information and interest we need to put into it, it's a pretty good comparison. We've also already heard this morning from Mark that we have some pretty big issues in terms of disparity. And when you look at the registration rate of this cancer for Maori, which is about 84 men per 100,000, it is much, much less than the non-Maori rate of around about 100. And yet the interesting thing is that when you look at the mortality, you find that the mortality rate for Maori is just that much higher at about 70%. And I guess if you're really looking at a reason for this, this has nothing to do with diet, this has nothing to do with particularly where you live. This is an absolute case control study of what happens when men do not get adequately screened or checked for prostate cancer. And as Mark eloquently said earlier, this is caused by Maori men presenting late. And I guess if there was ever one issue that we needed to correct in this population, it is the one of disparity. And that is something that we're all going to need to work very hard on. The other thing about prostate cancer is that there are some similarities and differences between this and other cancers that we really do need to take into account when we are managing the disease and we're looking at putting forward quality things that we need to improve. I guess the most important thing is that what makes prostate cancer similar to just about everything else is really the complete no-brainer that the earlier you detect this disease, the greater the chance of cure. And that is just straight common sense. Whether you're dealing with breast or prostate or bowel cancer or melanoma, you need to pick it up early if you want to get the best chance. So that's the trick, knowing how to do that. The other thing is the awful amount of talk about PSA. And we hear about PSA being this test that has all of these particular limitations. But let me just emphasize that as a practicing urologist, and there are a few of us in the room today, I can absolutely promise you that PSA is an excellent and essential test for us. And I guess we've heard a lot about this recently, and we've heard from dear old Dr. Ablin, who claims to have discovered the PSA way back in 1969. He actually was not the first, but he did actually contribute to its development. And in fact, PSA has been so important since 1969, mainly because of its forensic use, and it was used and still is in cases of rape. And the reason for this is that PSA is produced in copious quantities and is found in copious quantities in the semen, and therefore its forensic use is very, very important. But it was actually a urologist, Professor Thomas Stamey, who was the professor of urology at Stanford University, who cottoned on to the use of PSA in serum. And it was Stamey who actually popularised the use of this very, very important compound in the diagnosis and management of prostate cancer. So it's just a few little things for us to keep in mind. The other thing about prostate cancer and PSA is that as a urologist, we cannot do our work properly without the use of this particular blood test in managing men following treatment. And in fact, it is the single most important determinant of how disease is progressing or whether we have reached that sort of magic word cure in terms of the management. So let's not be too critical of PSA as a test. It's got its limitations, but it is certainly one of our hallmarks and one of the mainstays of the management of this particular disease. The other issue with prostate cancer, and this is what makes it a little different from some of the others, is that we know that when we make the diagnosis, we do come across some prostate cancers that may remain indolent for many years. There has been a little bit of criticism because pathologists have been, I guess, incorrectly labelled as being unable to determine what the cancers are that are going to progress or what are not. I'm going to make a little bit of a comment about this a little later. I'm not a practicing pathologist, obviously, but certainly there is a lot of work going on about this, and as part of our quality improvement program, I'd like to share with you some really, really interesting and important developments in terms of pathology and some little changes that are going to occur to this Gleason grading system, and we'll have a look at that in just a few minutes. The other thing about prostate cancer is that if you're going to cure it, you are going to have adverse effects. And this, with prostate cancer, seems to have hit the limelight. We're going to have men with erectile dysfunction, we're going to have men that are incontinent, and we're going to have men that may have had some impact on their quality of life. Well, sure, that is the cost of cancer treatment. And whether you have surgery or whether you have chemotherapy or whether you have radiation therapy, and once again, whether it is breast, bowel, lung, melanoma or prostate, that is the cost of having treatment. And I think it's particularly unfair that prostate cancer gets singled out a disease that many people feel should be treated without any adverse effects. Now, that is simply not the reality of life. Our role is to try and minimise risk, and I think we need to make sure we have well-informed patients so that when men and their families commit to treatment, they know what they're in for. But I think we just need to state right from the start, when we're talking about this disease today, that we need to work in a real-world environment. So I will leave that with you. As we heard from Mark, in 2009, the Parliamentary Health Select Committee was established and discussed issues related to prostate cancer. And I guess this was mainly in the context of screening programs for breast, cervix and bowel. And prostate cancer came under considerable levels of interest. There were vast numbers of submissions, and what the Health Select Committee determined was that the potential harms of a screening program outweighed the benefits, and this has been borne out by just about every other country in the developed world now having a similar stance, that there would be no population-based screening program. However, and I think this is to the credit of the Health Select Committee, they did determine that there was a great need for a quality improvement program that would include making sure men and their families were more aware of this disease, and for that reason the task force was established, and what we were really asked to do was to provide the clinical content and make some key recommendations that would inform, at this time, a yet to be established quality improvement program. So that is how the framework started. With the task force, there are a long list of recommendations. I mean, looking around the room, I'm pretty certain that most of you would have at least scanned through the document. You'll see that there have been recommendations made with respect to the public domain, and this is certainly to ensure that the information that gets out to men and their families is relevant. It's very, very clear, so it's not ambiguous, and is certainly culturally appropriate. We've also spent a lot of time re-emphasising the very, very critical role of the general practitioner and those working in primary care, which includes the very important role of the primary care nurses. We've looked at indications where general practitioners should and maybe should not refer the men with potential prostate cancer to specialists. We've looked at prostate biopsy, and I'm going to talk a little bit about that in some detail, the treatment options, and also towards the end of life care and the situation where we're looking at the palliative care situation. So the task force had a very big remit, and we were very fortunate to have some very talented people on board. And just looking around the room today, I need to point out that we've got Dr. John Childs in the front, who was on the task force. He's speaking today. Professor David Lamb on the far corner over there, who was also on the task force, and Dr. Rod Studd, who will be talking this afternoon also. So we've had we've been very, very lucky to have some very, very talented people on board. And with our working group, which is the current framework that we're working under, that I chair, we've divided up into 3 basic sections, and we've got Dr. Tim Malloy, who is the president of the Royal New Zealand College of General Practice. He chairs the primary care subgroup, so we're pretty certain we've got the right guy on board with that. My friend and colleague Steve Mark down here, who you have heard is the chairman of the New Zealand section of the Urological Society of Australasia. Steve chairs the specialist care group. And Professor Brett Delahunt, who is currently overseas at the moment, he looks after the pathology group, and Brett is a particularly distinguished pathologist. He is past president of the International Society of Urologic Pathology, and he has managed to get on board some of his friends and colleagues. One of them is Professor Lars Egervard from the Karolinska Institute and John Shrigley from McMaster University. And these very able and distinguished people have been working very hard on ensuring that the New Zealand pathologists are going to be brought up to speed with some of the very, very latest and very important changes that are occurring, and I'm going to share some of those with you. Okay, public domain. Earlier this year, this went out, some pamphlets containing information for men and their families. You know, a huge amount of work went into this, and we worked with Learning Media to get these documents out, and this was basically put together by a group of men and women and their families, you know, and we thought these documents were really excellent, and they were designed to break the ice. They were designed to initiate the awareness, and these were put into general practices surgery so they could become available for patients. You'll be aware that this created a little bit of controversy that we had to deal with at the beginning of the year. It was actually a very, very small number of people that didn't like this going out, and they were critical of the fact that we didn't have enough numbers in there. And the reason we didn't have detailed numbers and a lot of detail around percentages, around complications of surgery and other various treatments, is that we wanted this to be a global document. And these ordinary people, these are non-doctors, non-clinicians that really put this document together, believed quite sincerely that this was the best thing for men and their families that could go, and we're sticking by that. And I guess I'm putting that up there because we're aware of the importance of the public domain, so watch this space as our program gets further and further underway, and once we've got a lot of the work underway for the general practitioners in particular, we will then be at a time when we can start getting much more public domain information out there. Primary care, of course, is where it all happens, because first of all, men need to get to their GP, and once they get there, they need to be confident that the general practitioners have the skills and the knowledge and the wherewithal to know how to deal with this problem. And so there are various things that we have done or are working on to help GPs get this, and we've already heard about the Midland study, which is a very interesting piece of work, and I think this highlights a lot of the issues related to general practice. One of the things is the development of this thing called a decision support tool. So as you're aware, general practitioners have a patient information management system. So when you're looking there, they'll have their computer screen, and the sort of stuff that we're going to have is as part of that process when a man walks in who either wants to talk about prostate cancer or may have certain symptoms, there will be guidance on that particular program to help the GP know when to refer. And so we've got some referral guidelines sorted out. We also have heard from the GPs the importance of what they regard as the ability to actually track prostate cancer patients against agreed care plans. And we think this is a very, very important initiative. And once again, this is the sort of thing that is underway at the moment. And of course, e-referral processes are very important in terms of that comprehensive link between primary care and the specialist or hospital environment. On Wednesday of this week, and this shows you're really getting the current information here, so this is not set in stone, but a few weeks ago, myself and Steve Mark and those that were involved with one of the groups went through, and we have devised this system here of what happens when a man goes to their general practitioner. So this has not been signed off or approved. We think it will, but this is the sort of guidance that we have developed, and you're going to look through this and think, wow, hey, that's pretty simple. And it is a guideline. And one of the things about guidelines is that it's there so that if you really aren't too sure, it's a pretty safe lowest common denominator on which to work, okay? A lot of people are critical of guidelines because they believe they tend to oversimplify complex problems, and they do. And so this is only guidance. And if you have someone that believes they are a hot shot at dealing with patients with potential prostate cancer, sure, you can deviate from this. But as a reasonable common ground, this is how we go. So these are the sort of problems that men might present with. Erectile dysfunction or blood in the urine, they may have bone pain. And what we're signalling to GPs is that as part of the process, if you get a guy like this and you don't know what the cause is, for goodness sake, think about prostate cancer. And it comes back to the quality aspect of care. When we see this as a urologist, we always think in the background, okay, maybe we've got a guy here who's got advanced disease causing these symptoms. Similarly, we might have a man who has absolutely no symptoms in the world, but he has decided, after being informed of what it's all about in terms of potential risks and all the subsequent things that can happen to you, he may have had a PSA blood test. And so what we're putting out for the GPs is a series of numbers here which are age dependent on what we believe are reasonable thresholds for referral. What happens if the PSA is borderline? This is what you do. You simply repeat it after a few months, and so on down through the flowchart. And you can see it's pretty basic stuff, but this is just such an important start in getting the message across about how GPs in primary care can have a satisfactory method of referral that they can be pretty reliant on is going to do the right thing for them. Okay, what sort of stuff are we dealing with in pathology? And you might think that when pathologists look down the microscope and they have a look at a prostate biopsy and you were going to get 100 pathologists in the room, that those 100 pathologists would all come up with the right diagnosis. Well, they don't. And so this is a global thing. And one of the very important issues for us everywhere, and this is one of the things we are starting off in New Zealand, is to make sure that we have consistency of reporting. And you know, you can't, as a specialist, whether it's a urologist or a radiation oncologist like Dave and Steve, you can't work properly unless you can be certain of what you're dealing with. And certainly in New Zealand, we're actually pretty jolly lucky. We've got really top-notch pathologists, but there are issues that need to be resolved, and this is why we've got Professor Lars Egervard from the Karolinska. He's already devised a program designed to help pathologists come up to speed with the diagnosis of pathology specimens so that we can get a lot more accuracy and consistency in the reporting. The other thing of interest is our cancer registry. New Zealand has one of the best cancer registries in the world, and we're one of the countries that is lucky because every man and woman has a unique NHI number. It's an identifier as a patient. Believe it or not, there aren't that many countries in the world that have this. And at the moment, there are some changes going on to our cancer registry that just not enables storing data on tumour grade, whether it's melanoma or bowel or breast or prostate, but is starting to include information on stage, the degree of spread. You're probably not aware that we don't actually have that information in our cancer registry at the particular moment. At present, we've got a bowel study going on using Middlemore Hospital in Auckland. They are the first to start looking at that, but we are certainly hoping that prostate cancer will not be too far behind. Now, I've also given you a bit of a heads up on Gleason, and this is Don Gleason. He a little short chap actually, and unfortunately passed away a few years ago. Hey, not that I'm saying short is bad, you know, so it's okay. And he devised this grading system, and all you people out there will be well aware of this. And this is important because this is what we call a morphologic system. When the pathologist looks down the microscope, they're not too concerned about the actual detail of individual cells. They are really interested in what the structure of the cancer looks like. So here we've got a Gleason 1, which is very, very much like normal tissue. And as you can see, as the Gleason grade goes up, or the Gleason pattern, should I say, it becomes more and more disruptive. This is probably one of the best grading systems that are available for any cancer in the world, but it has limitations, and it's because it's morphologic. It depends on an ability to identify these different patterns, and it's one of the reasons why there is a little bit of disparity in reporting between pathologists. And so what is happening, and what is definitely going to be happening at the end of the year with a meeting internationally, is that this Gleason system is going to be revised. Now, this is by absolutely no means set in stone. I have been given permission to reveal this to you, and I can absolutely promise you, you will probably be the first public group in the world that have ever seen this, but this is what's going to happen. Surprisingly, the Gleason pattern 1 and 2 are just going to be chucked out. And the reason for that is that probably they don't actually represent cancer. And it doesn't come as any surprise to a person like myself, and I'm sure to Steve as a urologist, because quite honestly, I have never ever seen a Gleason 1 reported, and for me personally, I've never encountered it either. So we're actually starting with a Gleason 3 moving up. And so this is what the International Society, here it is here, of Urologic Pathology are thinking of doing. This is the working document at the moment. Gleason 3-3s, you'll be aware of this looking around the room here, will become what's called a 1. Whether it's an ISUP 1 or whatever, I have absolutely no idea, and I don't think anyone does. And moving down so that when we get these high-grade tumours, we're into a 4. So as part of our quality improvement program, we're going to latch onto this real quick, okay? And so one of the things in terms of pathology is we're just going to make sure that we are right up with this so that the New Zealand pathologists are right off the mark in terms of making sure that we have that quality aspect to pathology reporting. And so what it means is when the pathologist has a look down the microscope, this is a core biopsy of a prostate, they will be able to actually make the diagnosis with a great deal of confidence as to whether this is high or low risk, depending on the grade. And of course that is of vital importance in determining the type of treatments that are on offer, and also the likelihood of disease progression if you get this cancer. And getting towards the end now, in terms of specialist care, you'll also appreciate that this is a vast area. One of the important issues that the group that is chaired by Steve has been looking at is timeliness, and what that means is the time it takes to either get seen for a first appointment at the hospital, or maybe the time from diagnosis of prostate cancer to actually getting treated. Surprisingly, we have no database, no national outcomes database to monitor how men are doing in New Zealand, and this is one of the very important things that we are going to be looking to implement, so that when a man gets diagnosed with prostate cancer, his data are entered into the database, the treatments are entered, the outcomes are entered, and that is just so important because as a country we won't really know how we're doing unless we can get this sort of information together. Active surveillance is a biggie, and this is because it is becoming globally a much more accepted method of management. We'll have a look at this in just a second. We're going to have a look at some of the new curative treatments as a group. There's a lot going on now, and even for advanced disease, and I can see from the sponsors of this meeting today with Janssen, you'll be getting to hear an awful lot about new treatments that may have a different perspective for those men who with metastatic disease. Maybe it is not the more permanent and non-survivable cases that we're going to be looking at with these new treatments. So with active surveillance, and I'm just using this as an example of the sort of thing that we are looking at, it really is designed as a method of management for men with low risk, low volume cancers who are going to live for 10 years or more. And this is really, really important, because maybe we are having a group of men who will not need to undergo some of the more radical treatments like radical prostatectomy or external beam radiation therapy or radioactive seed implantation, and avoid the morbidity of treatment. If we are looking at this sort of thing, the sort of guidelines that we're putting together work down this. We've got the old Gleason system here. Remember, that's going to be changed at the end of the year, and we're aware of that. But these are the sort of parameters that we have been working on as a group that will help inform urologists as to the sort of criteria that we're going to be looking at. And I think Rod Studd this afternoon is going to be spending quite a bit of time going through that. And I don't want to steal his thunder, but just to put up front, it's the sort of stuff that we are looking at. And one of the things that Rod will be going through, I'm just going to signal to you, is that it may be a wonderful thing to think about with active surveillance, but it is certainly not for the faint-hearted. And the guidelines we're putting out, which are basically accepted internationally, is the requirement for quite frequent PSA and rectal examinations, but also the importance of repeat biopsy. And what has become very apparent from a lot of the international literature is that if you're going to have a man that stays on active surveillance, staying on it is not so much dependent on the PSA, it's usually ensuring that the biopsies don't show that there's been a quiet disease progression. So these are the sort of things that we're going to be looking at. And for men that exit active surveillance, these are the sort of reasons that you're going to get. And a lot of it is patient choice. It takes a bit of nerve to stay under active surveillance, particularly if you're on it and your PSA starts slowly going up, and also the preparedness to undergo repeat biopsy. Not always an easy thing for men to do. So the quality improvement program for New Zealand has been a very, very important thing. And for me, as chair of both the task force program and this more recent group, it's been a real pleasure. And you know, you may say to me, and a lot of people do, they say, what's it like working with these ministry people, you know? What's it like working with the Ministry of Health? And, you know, I'm going to tell you straight off that the staff at the ministry I've worked with have been absolutely outstanding. And they're not here today, although I think one may be, but with Emma Craigie, who is really working on the ground at the moment to put a lot of the stuff together. We've got Barry Porteous and Emily Barrett, excuse me, and Deborah Woodley. These women have been absolutely fantastic in terms of support, and I can absolutely tell you, when you're sitting outside ready to present to the Health Select Committee, it's quite comforting to have these people not just beside you outside, but coming to the room having done all the preparation. And I just want to put a plug in for the people that in the background just do so much work for us and so much work for prostate cancer in New Zealand. And I can see Minister Ryle has just snuck in down the back. Tony, nice to see you. And I need to put in a big thank you to Minister Ryle, who really has been of such tremendous support, and not just with the sum of money that's been allocated to this work, but really any queries that I've had, there's never been issues with discussing important things and as to where we go. So thank you very much. And on that careful note, just once again to remind you what we're here for. And this is a man with an isotope bone scan of metastatic disease. This is an old scan. We don't tend to do these anymore. And it's a bit of a reflection of the fact that when PSA came along in the 1980s, it caused a stage shift. We didn't see so much of this sort of stuff with men at presentation. But don't forget, at the end of the day, what we're here for is to improve quality. We want men to be able to make good decisions. We want them to be able to take care of their future in a much better manner. But at the end of the day, we need to save some lives. And we also need to stop the morbidity from this disease, because when men get to this stage, it is not always a happy existence. So thank you very much for your time. I think you're in for a really interesting day. We've got some wonderfully talented speakers on the horizon, and thank you very much for your attention this morning. Thank you.